My dear students, welcome once again to Glide the Slide. This gliding shall go on forever. This was the slide given to us as a homework, a slide for diagnosis, and the condition is, can you explain this to your juniors? Let us see what it is having. I am able to make out a fatty tissue. Multiple small dots are over here. Attempted aggregation. So probably these are all lymphoid follicles. The pink or the eosinophilic one might be the connective tissue. And there is a perinodal fat that is there. Also, I am finding a space within which multiple linear as well as oblique cross sections of something is seen. What is your diagnosis? Can it be an enterobius? Why not? And on closer view, what we can see is something like this. This is the cut surface of a parasite. A parasite generally has got a thick wall, which we call a cuticle. And in the cut surface, I am able to see two bag-like structures. Within this also, there are multiple small dashed-like structures which are there, numerous. So I hope you people are able to guess the diagnosis. And this, of course, is the connective tissue with a few lymphocytes in it. So the diagnosis in this case is microphyllary. Now what happens is, there is an organism which has got a cuticle or a sheath. And within that, I find that the parasite per se is. It has got numerous structures such as the oral style with which it is able to pierce also. There is a nerve ring, a bladder, and we used to call it as inner core. Now this is being called as nephridium. These things even I do not know the Raynaud's cells. There is an epidermis even in this because there is a cuticle and then there is a nucleated. There is an interior mass, probably some viscera are over here, then the pores of the anus. This is what is there, courtesy, study and scope. Here again, I am able to see the cut surface of this parasite, which has got two bag-like structures, within which multiple small parasites or microforms are seen. So this is the Wuchereria bancroft. This can be kept as a slide for us also, but be careful. This alone is not given as a slide. This is an adult parasite. So this will not be kept as one. The microphyllaria, on the contrary, in the blood can be seen. And these multiple dotted structures are otherwise called the nuclei, which can be discontinuous in some regions, which are the pores of inner pore, etc. The nerve ring. See, they are all called the nuclei. Now there is a sheath which doesn't have these structures. And so also the tail end, which is more tapering, is devoid of the other structures. So the parasite you should be able to identify by means of the sheath that it has got. This is a wet mount of the same parasite. You will not be able to see it, but it will be surrounded by the RBCs which are moving because of the wriggling motion of the parasite itself. The microphyllaria. See what you are seeing in this. The life cycle of the filariasis. Of course, the mosquito is the main vector in this region. It carries the third stage of the larvae and it goes to the proboscis or the salivary gland of the mosquito. And if at all it wants to take your blood, it has to inject what it has got in the salivary gland so as to suck the blood. That is exactly what happens, and the parasite is introduced into your body. Now, these develop into the adults and the lymphatics. It can be anywhere, but then by the blood and then the lymphatics, they are carried. There will be the male and the female. The female is longer, male is shorter. And the adults will be producing the sheathed microfilariae, which again migrate. They have got an affinity for the lymphatic channels. So they go over here. Again, at this stage, the mosquito takes a meal of you. Initially, it was feeding you. Now it is taking your blood along with the parasite. And you find there are 3 stages of the larvae. Stage 1, stage 2, and stage 3. After which, it again re-enters either you or another host. This is how the cycle goes on for any parasite. Even for Kala Azar, I had mentioned something similar. Kindly go back to it. Variety is the spice of life. We want surprises. Look at this. So this is the Wuchereria bancroftae. There is a sheath, no nuclei in the tail. Brugge malae, sheath. There is a distinct nuclei at the tip over here. Loa, again a sheath is over here. So these are sheathed forms of microfilariae. Then there is an Onchocerca volvulus in the skin. No sheath and no nuclei in the tip. Whereas Manzanella, it has got nuclei till the end. Manzanella ozardae, again, no sheath, no nuclei at the tip over here. And Manzanella streptocera of the skin, no sheath, no, but the nuclei will be extending up to it. The tip of it is quite blunt and hooked, as you are seeing. These are things. Now, these will not be definitely asked, but supposing you are a person who is just going to miss the gold medal by a mark, maybe this will help us. Now, what is the basic pathophysiology of it? The mosquito introduces the third stage of the larva and it invades the lymphatics and resides in them. What happens is, because of the chronic inflammation, there is something called a perilymphatic and a perinodal fibrosis that develop. In the meantime, the female introduces the microfilariae with develop into intact adult forms. As long as the parasite is intact, for that matter, any cell, so long as it is intact, it will not be introducing any inflammation or reaction. But there can be an obstruction, perinodal fibrosis. Because of the fibrosis, there can be puckering of the skin. And if this were to occur in regions such as the breast, it can be mistaken for Peau orange and it can mimic a malignancy. Generally, it is said that the patient is having a unilateral and a non-pitting edema. Thanks to Nisari for this wonderful picture. Sometimes there can be superadded infections. Acute and chronic inflammation can happen. The dead or the dying wounds can lead to a granulomatous reaction. Microfilariae, what will happen is they get settled in the perinodal lymphatics. That is why in the picture that we had seen, it is almost outside the lymph node, but still within it. It is the perinodal or the subsinusoidal spaces, the lymphatics, where it is. And the cycle continues to the third stage. It goes to man. Now, what are the diagnostic weapons for this? One, we had mentioned the blood smear, a thick smear, or a wet mount. Immunochromatography test is there. There can be a low blood protein. Eosinophilia obviously is there in any of the parasitic infestation. Imaging CT or MRI can be seen to see the obstructions in the major ducts such as the thoracic duct. Sometimes a calcified parasite. Your oral will be giving you a wonderful example of this. Retrograde pylography. All these can be diagnostic methods of it. Urine test. There can be the milky urine which disappears after a free fatty diet. Clearance of the urine by adding ether. Increased albumins can be presenting the milky appearance. And so also triglycerides and fatty meal. So these will have to be differentiated from the actual chyluria that you get in a case of filariasis. Walter and Estrell is a wonderful book on general pathology wherein he will be mentioning that the dystrophic calcification, one of the classical examples can be a dead fetus or a dead parasite. Look at this. A patient was once asked to bring his urine for examination. He brought this. And there was exchange of gesture amongst us, and then we said, kindly go and get urine. He came after some time, again a bottle was like this. So this is a case of a chyluria, milky fluid. It can happen in renal lymphatic obstruction, filariasis, schistosomiasis, any trauma or surgery where the lymphatic channels are damaged, thoracic duct aneurysm, fistula, nephrotics. So these are some of the differential diagnoses you people can have in mind. All chyluria need not be filariasis. We shall glide on to the next slide. The lesion in the oral cavity in a 55-year-old female. Describe, diagnose, and the differential diagnosis. Tusantak. See you in next class. By the way, what language is it?